Hello everyone, this is Mrs. Korea. Welcome to week 12 lecture. This week we are going to discuss about children with neurological conditions and sensory conditions and children with musculoskeletal disorders. Let us start with spina bifida, most frequently occurring and permanently disabling birth defect in the US. And it accounts for approximately 2/3 of all neural tube defects, which are birth defects in which the malformations of the brain and spinal cord occur and the structures lack protection of soft tissue and bone. The signs and symptoms vary depending upon the level of lesion and type of defect. Spina bifida occulta is the least severe form, which is characterized by visualization of meningocele or myelomeningocele, weakness, paralysis, and sensory loss. In the severe spina bifida, there will be visualization of myelomeningocele, neurological deficits, hip and joint deformities, and impaired bowel and bladder function. The diagnosis is prenatal diagnosis can be made if defect is visible through ultrasound examination. Then another test is the maternal serum testing of alpha fetoprotein during pregnancy determines the presence of a neural tube defect. So I just wanted to tell you a little clinical point on this. When you do the alpha fetoprotein testing, if the level is high, that is a possible indication of neural tube defect. But if the alpha protein level is low, that indicates Down syndrome. A good way of remembering this is Down syndrome, down alpha fetoprotein level or low alpha protein level, and high alpha protein level is for neural tube defect. Upon delivery, the spina bifida, some people call it spina bifida, I call it spina bifida, whichever way you can call it. Upon delivery, the spina bifida is visible defect as examined to determine type and severity. Content of sac are assessed for meninges, CSF, and spinal cord. MRI or CT scan identifies the neurological structure contained in the sac. Then the nursing care, the treatment depends upon the form of spina bifida. And in spina bifida occulta often does not need treatment, and more pronounced spina bifida creates risk for neurological complications including meningitis. Nursing care of spina bifida includes assess defect upon delivery for type of contents in the sac and measure the defect, prevent injury of sac and assess for indications of infection such as redness, purulent drainage, bleeding, necrosis, and if the sac ruptures and leaks CSF, patient is at high risk of developing meningitis. And we may have to administer medications such as IV antibiotics to prevent infection pre and postoperatively, anticholinergics to improve urinary continence, antispasmodics to control bladder spasms, prevent skin breakdown, laminectomy postoperative care, because laminectomy is often done in severe form of spina bifida. Then we need to monitor vital signs for signs of infection, perform dressing changes using sterile techniques, and assess surgical sites for redness, purulent discharge, odor, and CSF leakage, measure infant's head circumference as prescribed, and assess fontanelles for bulging and cranial sutures for separation, help infant maintain position that does not place pressure on surgical site, provide pain management to avoid crying-induced intracranial pressure increases, and education and discharge instructions include instruct on post-procedural care, emphasize the need to report signs of infection or worsening neurological deficits, educate on common medical problems that occur with spina bifida and interdisciplinary follow-up for these conditions like mobility, skin care, bowel and bladder function, and refer to community resources and support groups to help families to adjust to dealing with a chronic illness. Hydrocephalus. Some people call it as hydrocephalus. I say hydrocephalus. So this can occur due to three main reasons. If there is an increase in CSF production, an impedance to CSF absorption, that is any problems with CSF absorption, or an obstruction of flow. So as the fluid volume increases in the ventricles, pressure increases within the intracranial vault. The signs and symptoms are based on age as well as cause and rate of hydrocephalus development. And child may demonstrate signs and symptoms of increased intracranial pressure if disorder is severe enough, such as McEwen sign, that is tapping off on the skull near the junction of the frontal and temporal and parietal bone yields an unusually resonant sound, or you may call it as a cracked pot sound or cracked pot resonant. Child may demonstrate signs and symptoms of increased intracranial pressure if the disorder is severe enough, and they will have difficulty in holding the head upright, can have prominent forehead, head enlargement, and the diagnosis is based on signs and symptoms like increased head circumference, inconsistent with normal growth. And this, I have to give you an example that I recently had a patient who had consistently increased head circumference over 2 inches every 2 to 3 months, and it was undetected, and finally we diagnosed the patient was having a cyst, so that was causing obstructive hydrocephalus. That is why in the primary care, when the child is having health assessment, we have to be carefully recording them and plotting on the graph, and every time they come we have to compare the number and also look at the previous numbers. And diagnosis also can be made by CT scan, MRI, ultrasound, prenatal ultrasound that can reveal ventricular enlargement, and cysternogram evaluates the CSF flow in brain and spinal cord. Nursing care includes examining child carefully to identify presence of any immediate life-threatening symptoms, which is indicative of increased intracranial pressure or infection. Perform nursing actions to decrease intracranial pressure. Document child's head circumference to identify any major changes that need evaluation. Prepare child for endoscopic third ventriculostomy and or ventriculoperitoneal shunt placement. Education and discharge instructions include communicate that continuous monitoring and assessment is important for this lifelong disorder, and teach parents to recognize complications of hydrocephalus such as increased intracranial pressure and shunt malfunction. Education and discharge instructions also include teach parents to recognize complications of hydrocephalus like shunt infections, which can happen anytime and most often occurs in 1 to 3 months after the placement. Teach common signs and symptoms such as nausea, vomiting, headache, change in customary behavior, like any change in their behavior, lethargy, unresponsiveness, elevated temperature. Then explain that contact sports participation is not allowed due to the possibility of shunt damage, and emphasize the importance of safe transport and positioning. Cerebral palsy. This is the most common permanent physical disability of childhood, and which is characterized by physical impairment and mild to severe physical and mental dysfunction. Signs and symptoms include, it may vary depending upon the area of brain involved and extent of the damage, muscle rigidity, muscle spasticity, muscular hypotonia or hypertonia, poor control of posture, ataxia, demonstrate hand preference by 6 months instead of 12 months. So usually the hand preference should be attained after 12 months, but in this children you may see hand preference by 6 months. So for example, if some parents tell you that Well, I think my child is going to be lefty around the age of by 5 months or 6 months, then that is a red flag that something is wrong there. Then persistence of primitive infant reflexes. Remember, I have taught you about persistent Moro reflex may indicate cerebral palsy, and again crossed extensor reflexes, which if it is persistent also, and as a possibility of cerebral palsy. Diagnosis of cerebral palsy is based primarily on clinical symptoms and history of delay in reaching developmental milestones. CT scan, MRI, and cerebral ultrasound used to diagnose alterations in brain integrity, often present with cerebral palsy. Nursing care, we need to encourage independence, allow frequent rest periods to reduce muscle spasms and prevent fatigue, provide intellectual stimulation, choose toys based on cognitive age, not chronological age, and provide safe environment. Administer medications that reduce muscle spasms, and skeletal muscle relaxants may be used for short-term control with older children. Dantrolene or Dantrium to decrease spasticity, but monitor for hepatic impairment. Baclofen can be administered intrathecally via implanted infusion pump to provide continuous controlled relief. You might have heard about baclofen pumps. Neurolytic agents, agent nerve blocks provides some temporary decrease in spasticity for localized applications. Then botulinum or Botox injections for paralysis of specific muscles. Administer anti-anxiety medications like diazepam or Valium for older children to reduce excessive motion or tension. Phenobarbital and phenytoin may be needed to control the seizures. Surgical interventions may be needed to provide joint stability and balanced muscle power, like tendon lengthening, release of spastic wrist flexor muscles, correction of spastic hip abduction, selective dorsal rhizotomy. And education and discharge instructions include provide knowledge of expected growth and development, teach early detection of deterioration and signs and symptoms of infection, emphasize that healthcare needs are complex and will require multidisciplinary approach to improve health and functional outcomes. Retinoblastoma. It is a malignant tumor of the retina seen in children, usually before age 5, and it is a rare condition accounting for less than 3% of the cases of childhood cancers. And the tumor can spread to the optic nerve and invade the brain, lymph nodes, facial bones, and bone marrow. The signs and symptoms are cat's eye reflex. In that, remember in the newborn assessment, some of you had in Putnam, and they had, the neonatologist showed you the red reflex in the newborn eyes. So we should have a red reflex normally, and if that is absent, and if you see like a white reflection, that is a possibility of retinoblastoma. And late signs and symptoms include visual acuity disturbances, pain, inflammation, hyphema, that is blood in the anterior chamber of the eye. Diagnosis is based on the absence or abnormality of red reflex during fundal portion of eye exam, like I explained before. MRI confirms diagnosis and staging of tumor. Nursing care, the treatment primarily depends on the size and location of the tumor, age of the child, and degree of metastatic disease, and provide preoperative and postoperative education regarding treatment plan. And we need to educate on expected side effects, ongoing healthcare needs of the child, and prepare the family for postoperative appearance and or visual changes, pain control, and psychosocial support. So the surgical management is, if we can preserve the eye, they will try to preserve the eye and try to remove only the tumor. But a lot of time, when at the time of diagnosis of retinoblastoma, it is already metastasis. So the surgical procedure commonly done is enucleation, that is removal of the whole eyeball from the socket. So we need to educate, because it is very upsetting as a parent to see that, postoperatively, that the child's one eye is not there anymore. So we need to give really emotional and psychological support to the parents regarding that. The education and discharge instructions emphasize the importance of continued screening for recurrence, advise family members to have regular eye examination. Let us move on to the musculoskeletal conditions found in the children. We'll start with clubfoot. It is the common foot deformity diagnosed in newborns. And signs and symptoms are: the foot is plantar flexed, has an inverted heel, has an adducted forefoot, is rigid and cannot be manipulated into the neutral position. And the diagnosis is made by visualization during newborn nursing assessment. Clubfoot is treated with serial casting. Brown splint used after final cast has been removed. And several cases of clubfoot may require surgery when the infant is 9 to 12 months of age if it is not corrected, or it was not possible to be corrected with serial casting. Then after surgery, we need to observe for swelling in ankle and foot, elevate ankle and foot, assess for drainage from cast as well as for signs of infection, provide pain management. And education and discharge instructions include: instruct family to keep cast clean, use double diapering, change diaper frequently, give sponge bath, provide emotional support, use distraction techniques, and age-appropriate toys to meet developmental milestones. The next condition is Legg-Calvé-Perthes disease. Legg-Calvé-Perthes disease starts with an interrupted blood supply to the femoral head. And the signs and symptoms are hip or knee soreness or stiffness. So whenever a child comes with a painful limp, hip soreness or knee soreness or stiffness, you will have to be evaluating the child carefully. And pain that increases with activity and decreases with rest, that is a very identifying feature of Legg-Calvé-Perthes disease. So the pain increases with activity and decreases with rest. Diagnosis is made by a radiograph, and nursing care includes obtain history, pain description by the child, assess range of motion, non-weight bearing using brace, assess skin for breakdown, bed rest, manage pain, and after surgery, hip spica cast is required in case if surgery is needed. Education and discharge instructions: avoid weight bearing activities, remember this, and mobility instructions maintained, range of motion exercises, emotional support, and diversional activities. Ohrsrud-Schlatter disease. I have included this topic because you will see so many children, especially in their teenage years, who play sports, come with this problem in the doctor's office. That is why I have included this topic. It is a very common problem. Not everyone really paid attention to the word, the Ohrsrud-Schlatter disease, the word as such, but it is a common problem in teenagehood. So it is the painful prominence of tibial tubercle. You will see some teenagers come with pain below the kneecap, so that is the time you should suspect this one. So upon assessment, you will see a painful prominence at the tibial tubercle, and pain below the kneecap, pain on squatting or extending knee against resistance. And the diagnosis is with the radiograph of knee or from the signs and symptoms. Nursing care is pain management, ice, elastic wrap, And education and discharge instructions limit activity, help the child to cope with activity restrictions and upper body exercises. So especially these children, they are involved in the sports, so you have to tell them that they need to limit the activity to treat this disease conditions, because if there is no activity restrictions and if they just keep playing the sports and activity, and it is going to get worse. So they need to be like, okay, 3 weeks, they should not involve in sports or something like that. Osteogenesis imperfecta. It is otherwise known as brittle bone disease. Signs and symptoms are lax joints, small weak muscles, and also the frequent fractures. Then you should suspect osteogenesis imperfecta. Diagnosis is the clinical symptoms and level of disability. Radiographic studies shows multiple fractures. Care includes teach parents to watch for signs of fractures such as irritability, fever, and refusal to eat. And olpidronate therapy, that is the bone resorption inhibitor. Then bisphosphonates, postoperative care, that is if there are fractures, you want to do the surgery and fix them. Discharge instructions and education include play and physical therapy, range of motion exercises, ambulatory devices, genetic counseling, protect child while allowing as normal life as possible. They can do activities which are not very strenuous so that they are not fracturing bones frequently. And that is all about this week's lecture, and thank you for listening. Have a good day.